frontal plane because it's the plane of the walking. So if you make, as in this example, just a translation, this is just a translation, a cranial translation of the distal segment related to the proximal. This should be here. Now it's just translated cranially. As long as the mechanical axis is preserved, this does not affect the joint orientations. So I agree with you that a better alignment would be nice to be gotten, but this translation is not going to affect the walking or the running of the dog. Would be different in the transverse plane in a case of a varus or a valgus deformity, because valgus or even more torsional deformity, because with this kind of deformities we can get a patellar laxation. But if you get just a translation in this plane, in the sagittal plane, and the bone heal here enough for weight bearing as it was here, even though this side didn't heal, or maybe not at the time, that was enough to sustain the weight bearing. This is not going to affect the walking of the dog. In fact, the dog was walking, still limping, but I believe that the lameness was more because of the implant and the pins through the muscles than because of the fracture, because the fracture at 8 weeks was healed, and the healing was so fast because I did that closely, with not touching the vascularization, because that was an adult dog. So it is important to preserve the alignment of the dog, but there are planes that are unforgiving planes, and the sagittal plane is the more forgiving of the planes. Why this? Even though if we make a femur a procurvatus one or a recurvatus one, if we get a fracture in a femur, as for example a fracture here, a comminuted fracture, and we do minimally invasively or with an external fixator, and at the end we get a proper reconstruction in the frontal plane, like this. This is what we aim to. If we get not a proper one, and we get some sort of a distal varus or valgus, as in this example, we are going to get a medial or a lateral patellar laxation, depending on where varus or valgus. But if you do the same mistake in the sagittal plane, and this is the femur in the sagittal plane with the fracture here, this is what we would do in an ideal world. And instead of this, if we get this, a so-called hockey stick femur, this is not going to affect the walking that much, because we have a rounded surface in this plane on a rounded surface because of the menisci distally. So around on around. So you can play a little bit more in this plane. You can make a little bit of mistake in the displacement here with no affecting the joint. While if you make a mistake on the other plane, in the frontal plane, as this is the frontal plane, or in the transverse plane, so this is the transverse plane, this is going to affect the patella to be luxated, or the dog walking with an external rotation of the limb or an internal rotation of the limb. So the sagittal plane in both the femur and the humerus is the less forgiving. So we can make little mistakes here, but not the same as in the frontal and in the transverse plane. You have another question?
В последнем случае, там где был открытый перелом первого типа, если с момента травмы прошло 4 или 6 часов, мы можем использовать внутреннюю фиксацию?
Please, can you? I missed the translation. Sorry. Can you repeat the question?
В последнем клиническом случае, где был открытый перелом бедра первого типа, если с момента травмы прошло около 4, 2 или 6 часов, мы можем использовать внутреннюю фиксацию?
I believe we can. I've done this also after a few days. And the concept that anything is open should be treated externally, and everything that is closed can be treated internally is a misconcept nowadays. So I've done many open fractures with plate and screws, and many with locking internal fixators, so plate and screws locking with no issues. As soon as you make the fracture stable and the vascularization start healing, blood supply is provided, and also antibacterial drugs, antibiotics are provided, and white cells can get there and fight the infection. So the most important thing is to have the fracture stable. Please.
Последний клинический случай. Вопрос, что вы думаете по поводу возможности постановки LCP импланта под кожу? На расстоянии от кости. На длинных винтах. Не будет ли это?
Yeah, it's a good option. It's another very good option. And in a locking plate, in a minimally invasive way to do that, sure, I agree. And also another option could have been plate and rod, to put an additional pin, 30% the diameter of the inner bone to support together with the plate, another option. Or another option again could have been conventional plating and screws, 4 screws proximally, 4 screws distally in addition to the rod. Sure. The hybrid external fixator. Also a tie-in configuration. There are many ways to do this, to treat the same fracture. That was just my choice in that moment. So, and when you make the choice, you discuss with the owner, you have financial issues and things. For sure, this this external fixator I use in that dog maybe is more expensive than any kind of plate and screws. So sometimes also external fixator can be more expensive than internal one. The good thing of an external fixator is that you can reuse it many times. You just replace the screws, you just replace the wires and the pins, the threaded pins. Yeah, it's a good option. So we can go from, do you mind if I jump from a topic to another related to the question you asked me? So we stay, or you want to follow exactly the program, the agenda? I don't know, are you more as Swiss people or more similar to Italian people?
Step by step.
Step by step, okay. So let's move with this, following the agenda. So fractures in cats. Cats are not little dogs. So in cats, they tolerate external fixators when they are good cats. But with external fixator, sometimes we need to manage the external fixator on a weekly basis. We have to recheck. We have to clean. We have to take x-rays more often because we want to remove the external fixator as soon as possible. With the plate inside, we can tell the owner, come in 8 weeks, we check. If we see a radiographical healing, your cat can jump again on the furniture. So the only thing you need to know is that I don't want your cat jumping on the furniture during the healing time, both with the external or the internal fixator. But sometimes with the cats, they tolerate less the external fixators, especially where they are not really domesticated cats, or they are not so easy to manage. So we are somehow obliged to put something inside. This case is I would say, a simple transverse, rare transverse fracture, almost transverse. So that means that the cut is almost perpendicular to the long axis, the mechanical axis of the bone, of the distal femur, of a cat not manageable at all, with an owner not able to come for rechecks. No financial issues. Is an adult cat. I see no physis here, so maybe it's a two-year-old cat, an adult one, maybe a female or a male. We really don't care the sex in orthopedics and traumatology. We care little, not as in gynecology, for example. And so in this case, how many of you would opt for an external fixator? We don't. We wouldn't, because it's not manageable. So we would go for an internal fixator. Have we got enough room for 3 screws distally and 3 screws conventional, three conventional screws proximally? Maybe with a reconstruction plate. You can bend the plate in the sagittal plane. How many of you would approach this cat laterally, the lateral approach? How many a medial approach? No one, only me. It's possible. The medial as the lateral distally is possible. And we got acquired with the medial approach to the distal femur when we do deformities. Why this? Because when we do deformities correction at the proximal tibia, as a TPLO for example, in a dog with an excessive distal varus deformity, we approach the tibial from medial, and so we extend the approach proximally, and we plate also the femur medially. It's doable. But we can do also from lateral. I agree. Maybe because we got used to do the lateral approach for the fracture, so we do laterally. So how many would put a conventional plate and screw? Why? Why conventional, for example?
Перелом выглядит анатомически реконструируемым, и поэтому наша задача при помощи простой PLC, DCP или DCP пластины создать компрессию.
Yeah, I completely agree. I completely agree. So this is the perfect fracture to be compressed using a DCP conventional or reconstructive plate to be bent distally there. Yeah, what did I do? I used a locking system. I could have done also with a conventional plate. I didn't get any compression there with this. Actually, with locking plates, we don't need the compression as we do with the non-locking plates because we have locking systems. So the locking plates, they work as external fixators. The difference is that they are inside the skin, in contact to the bone. So we don't do any kind of compression when we do external fixator, right? So as long as the fracture side is in contact, bone-on-bone contact, and we preserve and we allow blood vessel to cross the fracture side, this is an alternative way to reduce the fracture. Here the screws are too long. I was a little bit drunk that day. I got the wrong measurement all the way there. And this is the clinical, the radiographical healing in 7 weeks with this fixing plate, with a callus formation there. It's not surprising me. Think on if you put there an external fixator, you would see the same, callus formation. So the way the bone is going to heal with the and not too rigid, but with an elastic kind of reduction, as this was, is through callus formation. Well, it wasn't a direct healing. And we don't look necessarily to direct healing. Doesn't mean the direct healing is faster than the healing with the callus formation. So it's an option, it's another option. And the interesting thing, I put this case in the slide, is to show the way the bone is healing through the callus. And we don't see the callus underneath the plate, maybe because of the projection, but I wouldn't expect to see the callus on that side. But on the other side, where it's more elastic, at the same level, the rigidity comes from the plate. So underneath the plate is really rigid, and away from the plate is going to flex a little bit, promoting the callus formation. That is really good for healing. But with an internal fixator, really stable, the cat was able to do whatever. I asked the owner not to let the cat jump on the couch or especially on the table, the kitchen table or the furniture, but the cat was really comfortable with the plate inside. Not as it would as the dog we saw before in 8 weeks with the external fixator. And that was the follow-up in 7 months with the callus that was reabsorbed. No issues with the stress protection. I see no reabsorption there. That means that the bone is perceiving, is feeling the weight bearing. So it's still working. If you put a plate too rigid, too much rigid, the bone is going to reabsorb with a locking plate. That is not going to happen with a non-locking plate, because over time, non-locking screws tend to lose themselves. You haven't got any issue removing a non-locking implant from a dog. You can remove the screws with 2 fingers. But if you go removing a locking plate after months or years, you still feel the locking there. You can have issues removing. So they are still working over time, over months, over years. And if they are too rigid, the bone is going to get reabsorbed a little bit. Sometimes up to be a clinical issue. I'll show you a case later. That was after 15 months. So when I do internal fixation, I want to check the dog or the cat over time to rule out any kind of reabsorption, that means stress protection, and in a 2 or 3 checkup. After 15 months, for example, in this case, I see no reabsorption, I can say the owner, okay, is going to live forever with this plate on with no issues. Because there's no infection, there's nothing, there's no stress protection, so I don't need to see you and your cat anymore. I'm sorry. The cat's still doing great after 15 months and doing the same things. Another case of a cat, a mixed cat, female, 3 kilo, 1 year old. How would you classify this fracture? I can tell you was not open, so it was a closed one, so no bacteria from the environment. In this case, is a 3 kilo, so a small cat, 3 kilo, not a big one, I would say. I don't know how big Russian cats are. For being in Italy, this is not a big one, 3 kilo. So a normal cat is 3.5. Big ones are 5 kilos, the Norwegian cats. So a distal humeral fracture, not involving the joint surface, but is a joint fracture. Here we are inside the joint, if you agree. So maybe we need an anatomical reduction. That was from a fall, maybe from the window, from the apartment. So a middle, not a high energy impact, not a low one, an intermediate energy impact. So vascularization, not in good shape, but not the worst. Is a 1 year old. We can see also from the phases of the olecranon apophysis here. And then what else? We see fragments. How many fragments do we see? At least 3, I agree. In addition to a little piece here. That maybe that piece is not reducible. Is that piece not reduced going to affect the stability in the big area as the distal humerus? I see you doing this with your head. I would agree. No. So maybe we can get rid of this little piece and use this, making into little pieces and use it as bone graft in the case we need it. Because it's not affecting the joint surface. Because the joint surface is intact, is not affected. So we've got a distal humeral fracture, intra-articular, not involving the joint surface, with 3 pieces. So we need to make a decision. How would we treat this fracture? How many would go? How many of you would go with a cast or a bandage? No one. No one would put to sleep the cat. But we still need to choose among external fixator or internal fixator. No. How many would go with an external fixator, not opening, just close reduction, maybe with traction as a magician, as a Harry Potter thing? No one. I agree. So we all agree we need a surgical approach, I believe. Or you are too shy, or we all agree with this. We need a surgical approach. So if we open, that means we're going to put plate and screws. I believe it doesn't make any sense to open and then to put an external fixator after reduction. The only reason why to do this is because I don't have plate and screws. But if I have plate and screws, whenever I open, I put plate and screws. Makes sense? So we do all agree we would put plate and screws there. How many of you would approach lateral? Here. How many of you would put screws here? No one. One. How many medial? From medial side? Only him. You can do anything. How many of you from caudal? Please. No. Okay. From medial, from lateral. The best surgical approach here is the caudal aspect of the bone. Why that? Because it's straight. The caudal condyle, the caudal aspect of the condyle of the cat, but also of the dog, is straight. So if you make the reduction there and you put the plate caudal, you can fix the. What did I do here? I used a lag screw, the conventional lag screw, to make the proximal segment from 2 pieces to just 1. And then I use the caudal approach to make the 2 pieces, the proximal and the distal, one with 2 screws proximally and 2 screws distally. These 3 screws are still too long. It was a drunk period of my life. Maybe I did it the same day, where that gauge fall on the ground. I would consider this a mistake, but not a big mistake. But the most important thing I was happy was this screw, because I put that screw not inside the joint. So this little mistake will forgive me, but this wouldn't. If I would put a screw inside the joint, I would ruin the joint forever, especially not making the hole, but leaving there the screw. So when I do this, you can do this with locking screws in the metaphyseal area of a bone. You just perforate the first cortex. You leave your hand soft until your drill bit is touching the second cortex, and you retrieve the power drill. So you are not going to perforate the second cortex. Would you call this a monocortical screw? I wouldn't. Why that? It's not a monocortical screw because in the metaphyseal region we have really little cortices, very thin. We can use this example. In the proximal area of the bone, or in the distal where the metaphysis is, we have cancellous bone. The cortex here is really thin. Where the cortex is thicker is at the level of the diaphysis. But at the level of the metaphysis is really thin, but this bone is filled by cancellous bone. So whenever we put a screw just touching the second cortex here, as in this example, I'm not perforating the second cortex, I'm getting one cortex, not the other, so